the way that Sermorelin works is that it will stimulate growth hormone secretion within a certain time frame. And we're able to achieve a larger peak in growth hormone as opposed to if we were trying to do this in a more natural way. And the interesting thing is that our hormone production, including testosterone and growth hormone, it declines with age. And that decline surprisingly can start as early as in our 20s, mid-20s. So in a way, it doesn't surprise me that men in their early 30s are starting testosterone therapy. But we kind of have to think about the therapeutic order of things and making sure that we identify the other hormones that are potentially involved. And so the problem with a lot of the testosterone clinics is they don't get the whole picture. And they may be jumping the gun on prescribing testosterone to younger men and even older population. And could we potentially use Sermorelin, or could we potentially use some of these growth hormone releasing peptides to improve testosterone production? It sounds kind of weird. Well, how can growth hormone do that? But it all comes down to improving overall cell function. And growth hormone, it's not just about building muscle and improving collagen production, which has benefits on, for our skin and hair. It's not just about fat loss. If we look at overall cell function systemically in the different systems in the body, it can improve glandular function. So it can actually improve our own testosterone production.
Now, in today's show with Elana Zinkov, we take a deeper dive into the therapeutic role of peptides, such as GHRP6, Sermorelin, and others. Now, this is not something that I have any personal experience with, but I am interested in it, and I thought you might benefit from some of the things that we talk about today. Because as we get older, we always want to optimize our lifestyle, our recovery, our sleep, and it seems that these are more sustainable strategies over the age of 45 or 50 compared to some of the alternative treatments out there that people might be using, such as Botox or surgery or who knows what, fill in the blank, Juvederm. There's a lot of purported anti-aging, particularly skin therapies, that I think have unintended harms and side effects and consequences. In contrast, the idea of using peptides to increase your endogenous and balance your endogenous hormones over time seems a little bit more sustainable to me, although the technology is quite novel and new. So I'm personally, again, just sort of looking at this on a cursory level and trying to figure out if this is something that I might want to embark upon over the next 10 years as I approach 50 years old. So I hope you enjoyed this conversation with Elana. It's brought to you by our friends over at myoscience.com, tools to help you optimize your exercise performance as well as recovery. Now, one tool that you may benefit from if you exercise is creatine. What makes the Creatine Enhanced Electrolyte Sticks by Myoscience different is it features 2.5 grams of creatine in the CreaPure creatine raw material form, which is the only creatine derived from Europe, not from China. Really unique form, along with sodium, potassium, and magnesium, because it turns out that creatine depends upon electrolytes to get inside your muscle tissue, your brain, and your heart. If you're putting creatine in your coffee or just drinking it with plain water, you're not going to optimize the absorption of that creatine. So you can optimize the absorption of creatine and help optimize your exercise sessions by going to myoscience.com. That's MYOXCIENCE.com, and use the code podcast to save at checkout. Elana, it's great to have you back on. I definitely want to dive into longevity, anti-aging, and peptides, and the role that they can play in stimulating our own endogenous growth hormone release. I think that's incredibly fascinating. And just to kind of set the stage, this study by Steve Horvath at UCLA titled Reversal of Epigenetic Aging and Immunosenescent Trends in Humans got a lot of airtime several years ago. And the protocol, I think you might admire this because last time you were on the show, we talked a lot about hormones, specifically DHEA and how that declines with age. But the protocol was metformin, growth hormone, and DHEA. And what they found is doing this for 6 months reversed epigenetic age by 1.5 years. And then we were talking offline how, well, if you were to give straight up growth hormone, it would make sense to have metformin because it screws up blood sugar.
Yeah, absolutely.
Anyway, I think this is incredibly fascinating because many people are using skin remedies and photobiomodulation, trying to prevent wrinkles, and doing hair transplants for, thinning hair. But in your practice, for supporting longevity and healthy aging, you rely a lot on, in addition to diet and lifestyle and exercise, peptides. Yeah. So how are peptides different when it comes to supporting growth hormone than just giving straight up growth hormone?
Yeah, absolutely. So the neat thing about peptides that stimulate our own endogenous production of growth hormone, one, they don't have the negative side effects that we see by purely giving someone human growth hormone. And there's different tiers of peptides that stimulate our own growth hormone secretion. The Sermorelin, for example, that's a really neat growth hormone stimulating peptide because it does not increase our growth hormone production beyond supraphysiological levels. So this is something that you can take long term, and it is something that stays in your system for a brief period of time simply to stimulate our own growth hormone production, whether it's at nighttime or post-workout. That's another time that we see the biggest spike in growth hormone. But we can get the benefits of growth hormone without being scared of getting negative side effects like we do with the human growth hormone.
Right. And some of those side effects would be like organ growth, jaw development. You look at the bodybuilding community, the people that have been doing a lot of growth hormone and insulin, usually their jaw, and sometimes you see the forehead around the eyebrows grow.
Yeah.
So yeah, that's super physiologic, which might help with muscle hyperplasia and building new muscle cells, but there's a lot of downsides with that.
Absolutely, like insulin dysregulation, blood sugar dysregulation. So we almost start to see, we might see improvement in like energy and, like you said, muscle building and sleep, but then we might start to see the opposite effect of now we're putting on a little bit more weight. Now we have a little bit more adipose tissue, and it goes back to the blood sugar and insulin dysregulation.
Yeah.
So peptides it's a double-edged sword, so to speak, because they've been misused, and that's what gets people into trouble. And there are so many benefits to them when they're used properly, and sort of in line with our own production, our own innate ability to produce these hormones, like growth hormone, for example. So even in my practice, I use peptides, but I use them in the context of everything else that I'm doing. And it may be sometimes that is the first thing that I use, especially in the context of improving hormone health, improving longevity, reversing some of the aging-related processes like inflammation and joint degeneration.
Right. And so you were talking about how if someone was, because you do Prolo and PRP in your practice?
I don't, but I refer out. Yeah.
So let's say someone has an orthopedic procedure, they ruptured their Achilles, or they have a banged up shoulder or something like that. Yeah. You would recommend some of these peptides pre-surgical to help optimize the environment so that recovery time is much greater or faster and there's less downtime.
Yeah, absolutely. And there's been a lot of studies done on this, even with testosterone, that if someone has optimal levels of testosterone leading up to surgery, that their recovery is just so much better. And there's less muscle wasting too, right? Because one of the things is like when you're recovering from surgery or any sort of invasive procedures, you're not moving around as much. Yeah. And I've seen it clinically where I can sort of compare different groups of people and patients. Those who are on peptides that stimulate recovery and tissue healing and regeneration, they bounce back twice as quickly compared to the folks who don't have the peptides on board.
Interesting. And the peptides that you're talking about, is it BCP 157?
So there's BPC 157. Yeah. So unfortunately, we can't use that anymore. We can do oral BPC 157, which can work really well as well. But particularly like Sermorelin, growth
to
hormone
stimulate
peptide.
Growth hormone. Okay.
Yep, exactly.
Okay. In preparation for this conversation, I downloaded this article that I'll put in the show notes titled "Beyond the Androgen Receptor: The Role of Growth Hormone Secretagogues in the Modern Management of Body Composition in Hypogonadal Males." I'm sure you've recognized all the testosterone clinics on like every street corner now. It's crazy. Men in their 30s are getting on testosterone.
Yeah.
But peptides have been used, specifically the Sermorelin, for like, I think one of the papers was in 1996. Like this has been used for such a long time. Yeah. So I like to look at things like that, whether it's a supplement or a quasi-pharmaceutical intervention that have a large dossier of a use and safety as a way to naturally stimulate And so what is it doing? So Sermorelin, if we talk about, it's helping the pituitary release more growth hormone?
Exactly.
Okay.
Yeah. So that's the exact effect that it has. And the difference between, let's say, a natural product that says that it stimulates the release of growth hormone, the way that Sermorelin works is that it will stimulate growth hormone secretion within a certain time frame. And we're able to achieve a larger peak in growth hormone as opposed to if we were trying to do this in a more natural way. And, the interesting thing is that our hormone production, including testosterone and growth hormone, it declines with age. And that decline surprisingly can start as early as in our 20s, mid-20s. So in a way, it doesn't surprise me that men in their early 30s are starting testosterone therapy. But we kind of have to think about the therapeutic order of things and making sure that we identify the other hormones that are potentially involved. And so the problem with a lot of the testosterone clinics is they don't get the whole picture. And they may be jumping the gun on prescribing testosterone to younger men and even older population. And, you and I were kind of talking about, could we potentially use Sermorelin or could we potentially use some of these growth hormone releasing peptides to improve testosterone production, which is kind of like when we talk about it, it sounds kind of weird. Well, how can growth hormone do that? But it all comes down to improving overall cell function. And growth hormone, it's not just about building muscle and improving collagen production, which has benefits on, for skin and hair. It's not just about fat loss. If we look at overall cell function systemically, in the different systems in the body, it can improve glandular function. So it can actually improve our own testosterone production. So this is where we can see, well, if we improve our growth hormone levels, can we improve testosterone? And the answer is yes.
And part of that is probably changing body composition. I think on the macro level, body composition and all that, but if you drill down on the cellular level, it might affect the receptors, might affect the actual gland, and maybe even purge some of the senescent cells. We were kind of talking offline how that might be part of the mechanism of action.
Definitely. So whenever we're talking about senescent cells, we want to make sure that we are improving cellular function. And anything that we can do to stimulate, to improve cellular function, which goes down to anything that improves mitochondrial function will improve overall cellular function. And this is why growth hormone benefits, they go beyond just physical sort of aesthetic pluses or, the perks that come with it, and really extend to all the different systems in the body and how the cells communicate between each other and how cells function overall.
Right. Now, using Sermorelin, am I saying that right?
Sermorelin.
For some reason, in my mind, I kept wanting to say GHRP6 because that's another type of secretagogue. I know in the bodybuilding community, a lot of people were doing that, but I think Sermorelin is GHRP21 or something like that. I don't know. There's all these different numbers, but do you see the insulin resistance and some of the side effects that you would see with supraphysiologic growth hormone release with some of these peptides if people are using these in like how you would prescribe them?
Not with Sermorelin. And again, because it stimulates the growth hormone secretion for a very brief period of time, about 12 minutes or so. A lot of these other growth hormone releasing hormones and peptides, they stimulate the secretion for a prolonged period of time, well above and beyond our natural, so to speak, production. And the peak is much larger and stays longer. And that is why with a lot of these, some of the other peptides besides Sermorelin, we need to cycle them. They're only used for maybe an 8-week period, and then you take a break for a couple of months, and then maybe you repeat the cycle or you bring Sermorelin on board, so you don't lose all the benefits. But we don't see the insulin resistance or sort of the negative drawback with Sermorelin compared to some of the other peptides that are supposed to be used long-term and are not supposed to be used, 4 times per day.
Right. Yeah, people generally can abuse these, especially in fitness applications. So this would be a subcutaneous injection nightly?
Nightly. Some people, it gives them so much energy that they can do it nightly. So then we resort to a morning fasting injection. And if someone works out in the morning, that's a perfect time to do the injection right after.
Interesting.
Because I mentioned this earlier, but the 2 times in the day where you get the biggest growth hormone peak is nighttime and also post-workout. So we want to be able to use these peptides in line with our circadian rhythm.
Right.
When we're sleeping and then after exercise and preferably in the morning.
Okay, so if you're an afternoon exerciser, you generally wouldn't recommend doing...
I wouldn't.
Okay.
No.
Just morning.
Yeah, if you're not exercising in the morning, but Sermorelin sort of keeps you up at night, then I would say just get up in the morning, do the injection, because that's also still riding that peak of our growth hormone production or growth hormone levels. But if you're exercising in the afternoon, we don't want to give you this pulsating release of growth hormone because naturally that's not when we're seeing the peak.
And do you see, because we see this with other hormones where you get endogenous suppression of the hormone release.
Yeah.
For example, if I were to inject testosterone post-workout, then my testes would naturally make less testosterone. Do you see this, or is that why you recommend the break? You said like you might do 6-8 weeks on, several months off and come back.
Yeah, absolutely. The body sort of figures it out really quickly what's going on. And the second that our glands sense that there's this exogenous form of growth hormone, and by the way, that relates to all hormones, even thyroid, for example. A lot of times if you prescribe a hormone and you see, wait, why did the hormones decline? Technically it's supposed to be more. Well, you pair that with this decline that happens naturally, the gland stops producing more of that hormone. So it's good to take a break unless you naturally do not produce that hormone, like hypogonadism, right? You just, regardless of a break or not, your gland is not going to produce, whether it's testosterone or growth hormone or any other hormone. So for that population, you don't really need a break because the gland is not going to produce any on its own. But for the majority of people who still produce some growth hormone and some testosterone, I'll say let's take a little holiday every once in a while.
Right. And how are we testing growth hormone insufficiency, or do you rely upon more symptom presentation?
Yeah.
So someone comes to work with you, they're like, hey, look, I'm in my mid to late 40s, early 50s. I'm not feeling as good as I used to, not recovering. I have achy knees and joints and this. Do you rely more upon that or the testing that we'll talk about?
I'll use both. And I would say it's not so much insufficiency because just like with adrenal fatigue, so to speak, it's not an insufficiency, right? It's suboptimal, potentially cortisol regulation. Same thing with growth hormone. Now, I do have individuals who do have a deficiency in growth hormone production. So that is technically an insufficiency of growth hormone. The majority of my clients, they're experiencing both the suboptimal levels paired with symptoms of low growth hormone. And this can be poor sleep, poor recovery after exercise, also exercise performance. So during exercise, they're not feeling as strong, as well as potentially hair loss, premature wrinkles. Those are some of the major signs. And overall, they're just not as sharp or as focused. And I definitely have clientele who, they're sort of borderline. They have okay IGF-1 levels, which is a precursor or byproduct of growth hormone breakdown. So they might be borderline, but they have the symptoms. So I'm always going to treat the person, not the lab range.
Sure. And is this important to measure fasted?
Yes,
or in
absolutely.
the morning, the IGF binding protein?
Yeah, absolutely. Okay. Because our hormones overall are at their peak between about 8 to 10 a.m., which kind of makes sense because we want to get ready for the day and in line with our circadian rhythm. And if you test on a full stomach, chances are your levels are going to be a little bit lower.
And you said borderline or quasi low. What's an ideal IGF binding protein or IGF level? Is that contingent upon age or?
Well, so if someone has, let's think of kiddos who have a growth hormone deficiency. It's not even age related. And I have had patients by conventional standards, they're like borderline deficient but they're like 1 point away or 2 points away from being flat out deficient. And they don't get the growth hormone treatments and insurance won't cover that treatment. So we resort to things like Sermorelin, which is a lot less expensive compared to if insurance doesn't cover the human growth hormone derivatives. But, the ideal range is sort of 120 or above.
Okay.
And so if we see levels below 120, then that tells me that we do have some optimal production. And a lot of men and even women, when I see their labs, it's between like 80 to 90.
Really? So it's very common.
Yeah, very low. And then we get them started on peptides, and we could get them to 150, 170. And at that point, they're already noticing a lot of benefits from it in terms of recovery and endurance, strength. So we talk about grip strength, for example, right? It's a really important marker for longevity. Well, their grip strength improves, and they can do more pull-ups, they can do more push-ups. So we're seeing sort of the correlation as we improve their growth hormone levels, then their quality of life improves as well.
Wow. And how often would you see that being on the low end like that? Is that more common than not, or?
I would say not as common. Okay. I would say the most common, what I see is like someone comes in and their growth IGF-1 levels are like 140, 150, which is, it's a little bit maybe starting to be on the lower end, but they're having the symptoms. If someone doesn't have the symptoms and their levels are like 140, 150, as an example, I might not necessarily prescribe Sermorelin. Yeah. I'm probably going to work on some other things like improving mitochondrial density or function, reducing stress, working on diet, lifestyle, maybe some of the other hormones, because if their thyroid is tanked, maybe it's not necessarily the growth hormone sort of suboptimal levels that are causing some of the issues, but it's really the other glands that are underperforming.
That's really important to consider.
Have to get the whole picture.
Yeah. I mean, I think a lot of people forget, like, every single cell, thyroid hormone affects every cell, like in multiple different ways. So it's really, really important.
And it's not just metabolism. Thyroid affects actually how quickly your brain can recover. So it affects brain health. It also affects our immune system. So if someone is frequently getting sick, once we balance out their thyroid, they go from being sick every month to a cold, maybe once a year.
Yeah. And I'm sure treatment is individual. You might do micronized T3 or a glandular that has both T3 and T4. What would you say to people who are on Synthroid, right? Which just synthetic T4. Do you always like to add in the T3 element to thyroid?
It depends if they don't have a conversion problem, because we produce T4 and then T4 gets converted to T3. If someone has, let's say, Hashimoto's and they can't convert T4 to T3, or they don't have the nutrients, right, to convert T4 to T3, and sometimes even we balance out the nutrients and we still have a conversion problem, then we'll include T3 therapy on board. In the medical community, there's sort of two debates. On one hand, there's a lot of doctors that are like only T4 and they don't even bother with T3, even though it's 4 to 5 times more potent than T4. And on the other side, people are saying, no, only T3 or T4 and T3. And I'm coming from the perspective, let's test. Let's see, by giving T4, can we see the conversion happening? And if there's lack of that conversion, then we can bring on the T3.
Yeah. What's interesting about that is if someone has not addressed all their lifestyle factors, just giving the T4, it seems that they can actually feel, I've seen this over the years, worse because they're making reverse T3 from that T4 without getting any T3. So
this is where if you give someone T4 and their T3 doesn't increase, but their reverse T3 goes up, which is pro-inflammatory, then they have a conversion issue.
I see. So you're looking at, when you run thyroid labs on people, you're looking at everything: free T3, free T4, reverse T3, antibodies, all that, TSH.
Absolutely. And also like the nutrient levels as well, and cortisol, because thyroid and their adrenals have a very synergistic relationship. And so we want to make sure that the person doesn't have any sort of underlying adrenal issues, because if you give someone thyroid medication, but they have, let's say, adrenal insufficiency, which is a serious medical condition, then we may run into a problem where they might actually feel a lot worse. Yeah,
that's really good for people to consider. I mean, many clients I've worked with over the years, they go get their thyroid tested and it's only TSH, which is a pituitary hormone, right? So
I don't know why they still just do that. I mean, we've there's so much research that like TSH alone is not a great marker.
Yeah, no, it's pretty wild.
Yeah.
Okay, so going back to growth hormone, what are like 3 to 5 things that people are doing that is compromising their growth hormone release? Is it sleep? Is it we have insulin resistance, we have belly fat. Like, what are the main reasons why, in your opinion, people are experiencing premature suboptimal growth hormone levels?
I think right off the bat is poor diet and lifestyle choices. And if someone is up late, they're eating junk food, processed food, they're not optimizing their protein intake, and they're living a sedentary lifestyle, why would we want to prescribe Sermorelin when the first place to start is let's clean up our diet. Let's make sure that we're not eating junk food, processed inflammatory seed oils, right? That we're eating a whole foods, clean diet. We got to get to the gym or whatever form of activity people want to choose. But you know, sedentary lifestyle is just at the root cause of a lot of disease processes. But between the diet, the lifestyle, and, sleep, it's sort of a vicious cycle, because if you don't have enough of the growth hormone, you might not sleep as well.
Right.
But for women, for example, if we don't have enough progesterone, that's going to mess with our sleep. And if we don't have enough testosterone, that's going to mess with our sleep. So if we don't get the other hormones balanced, that might jeopardize our sleep and then our growth hormone production. So between the diet, the lifestyle, and the sleep component, I would say, and screen time is at an all-time high. And sort of like drinking clean water and breathing fresh air. Nowadays, we have to ask people, well, what are you doing before bed?
Yeah.
And I can't tell you how many times someone is listening to a murder mystery podcast. And I'm like, that's not the time.
Yeah.
That's not the time. You're getting your cortisol up. That's affecting your sleep. Or some clients, they have, their executive level position employees, and they will play video games and watch TV while trying to, then fall asleep 30 minutes later. And it's like, it doesn't work. You're sort of sending your body the wrong message. So we can work on improving the diet, lifestyle, exercise piece paired with our nighttime routine, but we also have to balance the other hormones that help us sleep.
Yeah, no, it's a really good point. But going back to the menopause or perimenopause struggle, a lot of women have sleep issues and everything, but
Absolutely.
I can see how the hormonal changes in progesterone and declining estrogen could impact sleep. And then that would, of course, affect growth hormone. So this is
Absolutely.
all very delicately, needs to be balanced and addressed.
It's an orchestra. It's a symphony.
Yeah, which is really important. So we talked a lot about hormones on that other episode, so I'd recommend folks check that out. But you have experienced a lot of benefits with oral progesterone for women. Even cycling women who are having sleep issues. Do you recommend oral progesterone? Of course, testing or
Absolutely. So there's a wave of younger women, and I think it's thanks to conversations like this, because even 10 years ago we weren't talking about this as much. And even social media, has come so far where women are sharing stories about their hormonal struggles, and people like you and I, when we're talking about the benefits of hormone therapy and can we safely introduce this. And just the other day, I had a perimenopausal woman who didn't know if hormone replacement was an option for her. And of course it is, because going back to our hormones can start to decline in our 20s. And some women, even in their teenage years, may not have optimal production of those key hormones. And if I test women's hormone levels, let's say progesterone, for example, and it's suboptimal, and we can't naturally boost those levels, like Vitex, for example, then I'll resort to hormone replacement. And it provides such relief, not just for sleep, but for mood as well, and hair loss and skin. Like, I frequently share my example. I struggle with PCOS, and I struggled with fertility and cystic acne. I wish someone had given me oral progesterone or even progesterone cream when I was in my 20s, because I grew up as an athlete. I knew how to eat. I knew how to move my body. I had access to sports psychologists, but I was still a mess. And so I wish that someone had told me earlier on, hey, it's not just herbs that can help you. If you're actually not producing potentially enough of this hormone, you can start on bioidenticals earlier on. You don't have to wait until menopause, postmenopause.
Interesting. Now, would you cycle the progesterone based upon where you are at in one cycle, like post-ovulation, or would you use it all the time?
It really depends on the person. So some women will benefit from just days 15 through 28. So day after ovulation to start on progesterone. Other women will notice that if they do that, they'll get 2 cycles in a month. And so the other side to this is that some women, if they don't cycle progesterone, they'll get 2 cycles in a month. It's very individual.
Wow.
And some women will require a lower dose, days 1 through 14, and a higher dose to mimic that peak in progesterone in the luteal phase, days 15 through 28. And, some women do better with oral progesterone, and some women will do better with a progesterone cream. It just all depends on, different pathways of how it gets metabolized and slow release versus more immediate release. So it's really individual.
Wow. That seems very complex to manage, because there's so many different outcomes based upon the same, input.
Education becomes key because, even as a physician, you're trained sort of textbook. If X happens, you do Y. In reality, a lot of people will respond differently, to different inputs. And when I place women or men on any sort of protocol, whether it's hormone replacement or peptides, I walk them through about all the possible outcomes and how we're going to manage them. Because some women, if we cycle progesterone, say days 15 through 28 or 14 through 28, they'll say, well, I feel great during that second half of the month, but I feel horrible during the first half of the month. So we have to introduce, whether it's the cream or the oral form of progesterone, so that they feel more even keel throughout the month.
Interesting. And if a woman is new to all of this hormone testing and they want to just go and get their labs tested, is it best to test on the first day of menstruation or around ovulation? If they just want to get a baseline, where would you recommend starting? Yeah,
I would say 2 times during the month that it's important to test, especially for younger women, let's say even in perimenopause or younger. The follicular stage, so this is usually day 2, 3, or 4, which is we're looking more at the fertility panel. We're looking at the ovarian reserve. We're looking at the FSH and estrogen levels to see, how sort of quickly our ovaries are aging and at the quality of the egg. And then the second time that I would test would be in that luteal phase around day 19, 20, or 21 of the cycle.
Okay.
And this is where we're looking for, do we see that peak in progesterone? And in proportion, how high is progesterone compared to estrogen and vice versa? Because what can happen for a lot of women, and sort of the reason why they experience a lot of the negative symptoms like PMS and breast tenderness and mood swings and even PMDD, it's usually because proportionally they have much less progesterone compared to estradiol in that luteal second half of the cycle.
I see. So that's the mood swings and all that related with menstruation is the imbalance between estrogen and progesterone.
Yeah.
Okay.
Yeah.
So why is it that progesterone or is it the ratio, or is it that whatever diet and lifestyle is contributing to low progesterone? Like what is contributing to that? Why?
Yeah. So some women naturally just don't produce, right? So it's just, not all glands are perfect, and some produce normal amounts, some just naturally don't produce. So we can resort to stimulating the glands like Vitex to produce progesterone, but the caveat is that it can also raise your estrogen levels. So you kind of have to monitor the levels. Or we can use herbal treatments to stimulate the receptors without necessarily raising our levels. But stress, right? Stress is the number one cause for different hormone imbalances. Diet, poor diet, lifestyle, right? If you're eating a lot of inflammatory foods, the cells are not going to get the message. And then environmental toxins like heavy metals, mold, for example, they can bind receptors and prevent the hormones from actually binding them. And this is what I see is when I prescribe hormones and someone's not getting better, I'm always thinking about, is the cell getting the message?
And then looking at other factors, as well.
Yeah.
That's really important. Do you think that we hear a lot about low testosterone and all the persistent organic pollutants and endocrine disruptors affecting fertility in men, but it seems that those same phthalates and BPA and all these things, they have an estrogenic effect as well.
Absolutely.
So it seems that they are equally, or if not more, harmful for women than men. What would you say to that?
The thing with estrogen is that, those compounds are more xenoestrogens. So it's sort of like estrogen to the power of 10, right? So a lot more potent receptor stimulation, disruptive receptor stimulation. And for women, we know from a lot of studies now, because the Women's Health Initiative has been completely debunked, is that it's not even synthetic estrogen and not even bioidentical estrogen alone that causes cancer, but it's actually even progestin more so. But, that's sort of a little bit of a sidetrack. But if we go back to like environmental pollutants and xenoestrogens and what they do, I think environmental toxins definitely pose a greater danger for increased risk of cancer, especially for women, breast cancer, uterine cancer, ovarian cancer. And one of the reasons is because, yes, there's this over receptor stimulation, because those environmental toxins compete with our own endogenous estradiol, which is, compared to xenoestrogens, has a weaker effect, so to speak. But if you think about someone who has a huge exposure to environmental toxins, they're usually obese or overweight because their cells they're not functioning properly. Right. They have insulin dysregulation, they have glucose dysregulation. And we know that, especially for women, one of the biggest risk factors for breast cancer is obesity.
Yeah, that's a huge point. And to that point, insulin resistance and obesity all contribute to accelerated aging.
Absolutely.
And I think, that's kind of coming full circle here back to growth hormone. I think it's all interconnected. But what you see people spending their discretionary income on is, say, Botox or Juvederm or, topical lasers and things like that, but really internally affecting the metabolic health, insulin signaling and growth hormone release, sleep, all of that really play a much, I think it's more of an upstream root cause resolution to optimizing longevity and aging and brain health.
Yeah, absolutely. You can spend thousands of dollars on all these cosmetic procedures, but if you don't optimize your growth hormone production, if you don't optimize your estrogen, testosterone levels, you're not going to get the same benefit. At least you're not going to get the same long-lasting benefit. Right. And I think it's important to, especially from even anti-aging perspective, in terms of inside out, both aesthetics and how healthy we are metabolically. It's okay to do those sort of external procedures, but not forget that you still have to do that internal work. Right. And there's no better way to stimulate collagen production systemically that can improve joint health, muscle health, and skin and hair health than with, our own growth hormone production.
Yeah, that's really important. Okay, so what's the controversy over these peptides recently, especially like the more novel Sermorelin analogs and secretagogues? Why has the FDA recently stepped in and started to throttle these back and prevent people from accessing this?
Yeah, the unfortunate thing is that there's a group of peptides, including CGC and ipamorelin, that have been pulled off the market because they have deemed to not be safe, meaning that they lack the data to support its safety. And I think a lot of it has to do with just how a lot of the peptides have just been misused. Yeah. Like anything, you could have a really great medication that gets misused by the public, and then the FDA pulls it off the market if it doesn't have the data. And, there's a little bit of controversy, like, well, there is actually data. And so we're trying to provide the FDA with the data that validates and no, this is safe, and here are the long-term outcomes, and here's data based on real patients, not just like research studies that were done previously. But the problem with like those peptides, like the CGC and ipamorelin, like Sermorelin, again, it won't boost your growth hormone levels beyond the supraphysiological levels. CGC and ipamorelin, they will long-term sort of keep you in this overproduction, overstimulation of your own growth hormone release. And just like testosterone, right? Like with all the testosterone clinics popping up, the DEA was like, this is not okay. We want to have this more under control. Same thing, I think the FDA is coming in and saying, you know what, this is getting a little bit out of hand. People are misusing this product in different ways and forms. There is a bigger access to it nowadays from different sources, good or bad. And so we no longer have it. But we have access to other peptides.
That's awesome. Yeah. And most of these peptides, are they made here in the U.S.?
Yes. Okay. Some peptides, so not from a growth hormone perspective, there's different category of peptides from a neuroprotective standpoint, as well as weight loss. Some of them have been produced in Europe.
Fascinating.
Yeah, but made their way to the United States.
Yeah, that's incredibly fascinating. Another tool that you found to be helpful is rapamycin and methylene blue. I would like to start out with rapamycin. We've interviewed several people, Peter Attia, over the years, talking about the benefits of rapamycin. Alan Green has a Rapa clinic in Long Island. This is classically prescribed as an immunosuppressant for people who have organ transplants and things like that, but low dose, of course, it has longevity benefits. How do you see rapamycin fitting into helping with inflammation and aging?
Absolutely. Aging is just this inflammatory process where, we see degeneration of collagen, and we see all the different systems, including our nervous system and even our reproductive system, starts to decline and function. And the way that I have used rapamycin and that I see it used is that it is slowing down that aging process by controlling inflammation. And of course, there's many different ways that we can control inflammation, but sometimes inflammation is like this runaway train for some people. Some women can be doing a lot of right things, but they have endometriosis. And it can be in stages where, nothing else is really helping. And so how do we take care of that inflammation? Rapamycin is a really effective product for that. And of course, when people Google it, for example, they're like, oh my God, well, I'm not getting organ transplant. Why would I want it? It is prescribed in much higher doses, not like 2.5 milligrams to 5 milligrams, which is proactive and preventative and can slow down inflammation. So for even patients with neurocognitive issues, whether it's dementia, Alzheimer's, Parkinson's, which all, we're talking about senescent cells, it really is poor mitochondrial function in the neuron cells. And things like rapamycin, not only can they reduce inflammation in a nervous system, we can reverse some of the damage that was done and prevent further degeneration. And so I've used it even for women in perimenopause and sort of on their way to menopause, postmenopause, to make that ride a lot smoother. So they're not just go from one day they're producing hormones to the next day they're not. And we're sort of smoothing out those fluctuations.
I love that. And I think another application I've heard from Alan Green would be ApoE44 carriers. And, people that have that genetic phenotype might benefit, cognitively speaking, from low-dose rapamycin or cycling that on and things like that.
And with that metabolic health, right? We want to make sure that those who have the E4 presentation, or even, E2, E4 or E3, E4, sort of on that higher risk, we want to make sure that we get their blood sugar under control, their triglycerides, their ApoB, their insulin. So this is where I will test people's insulin levels 2 hours after a meal to see, does it come back to normal or pre-meal baseline. And of course, because we know like insulin, too much of it's pro-inflammatory. Rapamycin can be used, especially from a brain protective standpoint, to prevent some of that inflammation.
That's awesome. Yeah, really good to know. Methylene blue. This, I think, has been used as a nootropic. I've tinkered with this over the years. There's a company in Canada that sent me some to try. I found it was good before cognitive intensive work, reading, writing, things like that. The only downside is it does stain your tongue and so on. How have you found methylene blue to work into this mitochondrial regenerative standpoint?
Did you take the drops? Is that why it stained your?
It was the drops. Yeah. And I was a little bit haphazard with it and just put it right on my tongue, and my whole mouth was blue.
And then you go out on a date and
it's everywhere. Yeah. I mean, it's kind of fun. I guess there was a party at Metabolic Health Summit in 2020 and everyone had blue tongues.
That's so funny.
Nicotine, methylene blue combinations. Yeah, it was interesting.
We can talk about nicotine too, because that's actually pretty fascinating. Let's talk about methylene blue, and then we talk about the nicotine patches and stuff, because that's really important too from a vagal nerve, immune system, brain health perspective. But methylene blue, so I like capsules instead of the drops.
Okay.
Because then it's not going to stain your tongue blue. It might stain your toilet, but it's not going to stain your tongue. So methylene blue is really interesting because it can work pretty quickly. And I usually see it used between 25 to 50 milligrams daily. The way that it works is that it comes down to, again, improving mitochondrial function and increasing the brain-derived growth factors that sort of help our brain repair, recover. It decreases that synaptic pruning that happens as we age. The way that I like to prescribe it is actually paired with red light therapy. And it's a photosensitizer. So it will improve the outcomes of red light more so than if like red light is used on its own. And it's sort of like a double punch effect where red light comes in and it really works on improving that intracellular mitochondrial density and function. And then methylene blue comes in and then it increases the brain growth factor production. So you have the synergistic effect on overall, focus, performance, and essentially improved neural function. So we're talking about even for people who are like Parkinson's, who, and Parkinson's is this, it's also considered an inflammatory condition. It associated with poor glucose metabolism. So anything that can improve mitochondrial function, especially as it pertains to brain health, it's a huge win-win.
Right. And would this be something that you would use daily or you would cycle it? Okay.
Yeah, there's no problem with using it daily. And again, it works really well. I even tried it. There was one evening, I had a really long work day, and I took my methylene blue and I have a red light at home. 20 minutes is what I recommend for people who have like a Juve or a Biomax red light. 20 minutes, that with methylene blue. And not only do you get restorative sleep, but you wake up just feeling much, much more sharp, better focus, and more energized.
That's so cool.
Yeah.
That really makes sense that it would be a synergistic sort of protocol.
Yeah.
I've never thought to do that. That's awesome.
Yeah.
So nicotine, we've talked a lot about that on the podcast. I think tobacco-free nicotine, people associate nicotine with cancer because of tobacco.
We're not promoting smoking.
Yeah, exactly. Thanks for clarifying. Yeah. So tobacco-free nicotine as a nootropic, there's some benefits there, maybe alleviating constipation, preventing Parkinson's. How do you view nicotine in this protocol? Or
I use it in terms of vagal nerve stimulation. So I would say that the nootropic component is a benefit of by stimulating the vagus nerve.
Yeah.
So when we stimulate the vagus nerve, we take ourselves from a sympathetic state to a parasympathetic state. And that's why we have better focus, we have clarity, and we feel more at ease and peace, and we can focus better and sort of get into the creative flow state. Right. The other really important component to this is that by activating or stimulating the vagus nerve, and there's many different ways to do it. The thing with a nicotine patch is that I shouldn't say nicotine patch, but nicotine, for example, which I do like to use the nicotine patch, is that it has a direct effect. So it's sort of that instant, immediate stimulus to the vagal nerve. So you could do tapping, you can do breath work, you can do a lot of different things, but there's really few things that would directly stimulate those receptors and activate the vagus nerve so quickly. So what I was gonna say is that it actually has immunoprotective qualities as well. So if someone is sick, let's say with a virus infection, and certain viruses, they prevent your immune system from working properly, by using nicotine, we can actually stimulate a more proper immune response. Or you're going to a conference or you're on a flight, you can actually get these immunoprotective qualities and properties from nicotine.
Wow. That's a really good, I think, under-recognized aspect of nicotine.
Yeah, absolutely.
It gets a little bit more complex, but yeah, the whole acetylcholinergic pathway and vagal nerve tone has been used actually for obesity, and where people generally tend to overeat and things like that, and then also inflammatory mechanisms. I know some bodybuilders who use this during their cutting process will have, and I don't like the Zins. I think they're just, I've tried those before. They make me nauseous right away. But they'll use that as a way to suppress appetite. So I don't know, it's kind of interesting. I had this boss back in 2006, and when she quit smoking, she put on like 50 or 60 pounds.
Yeah.
And so you hear those stories. So I think if you have a vice like junk food or nicotine, tobacco-free nicotine, I would probably steer more towards nicotine.
Yeah.
But yeah, it's highly addictive for some people as well.
Yeah. Well, the way that I've been prescribed it, if you look at even like the nicotine patch, for example, we use the lowest, which is like the 7 milligram, which for ex-smokers, that would be like a placebo almost effect, right? And so that I would definitely cycle. It's not something that I don't recommend that people would just wear a nicotine patch, all day long, every single day, because you do get used to it. And like your body gets used to easy things that feel good.
Yeah.
Right. That's like addiction is that, right? And so, but however, if you're going through, let's say, a stressful period in your life, or you are making a big change in your diet or lifestyle, and it's a hard change, and maybe you're someone who is underproducing serotonin or dopamine, and those habits are hard to incorporate, then that could be a really nice bridge.
Yeah.
So it's not such a painful process. And so, but we can use it safely without a lot of negative side effects or drawbacks. And I see people who have a hard time, let's say the vaping, and it's hard for them to quit. Even just a small dose of nicotine can bridge that gap from them vaping to them not vaping.
Right.
And it can be used as a bridge, but it can also be used as a tool on a day-to-day basis. Like if I'm flying to a conference and I know I'm either going to be presenting or it's going to be a 4-day marathon, I will use the nicotine patch mostly from a performance perspective. Now, metabolically, like I'm not in a place where I needed to use it as an appetite suppressant. I will still eat my protein and get my exercise in, but I'm using it from let's turn off that noise even around food, for example. Like, so you have healthy appetite cues, but also if you need to be on all the time and you need that extra edge of focus, then we do kind of have to use some of these biohacking tools.
Totally.
Yeah.
No, I'm all about it. Better life through chemistry is
Totally,
kind of motto. I think that's amazing. Elana, we could probably talk for days on all these different topics. If folks want to connect with you and work with you potentially, how would they? I know you do a lot. You share a lot on Instagram. Mm-hmm. What's the best platform? And then your website if they want to reach out. Absolutely.
So I'm on Instagram under Dr. Elana Zinkov. And then my website is drelanazinkov.com. And my clinic website is proactivehealthnd.com.
Cool. And then just for context, if people want to maybe do some of these more natural ways, if you will, to optimize growth hormone levels, cost-wise, monthly or 6 weeks, what does this look like for people?
Yeah. So it's about $400 to $500 for a 6-week course of, let's say, Sermorelin.
Okay.
And it's a lot cheaper, I would say, than, there's a lot of different clinics and pharmacies that compound it where it's a little bit more costly, where it's like $500 a month. And it depends on which peptide you're using. So some of the higher tier peptides like Sermorelin, which we didn't talk about, we can talk for hours and days about this, but like Sermorelin's a little bit more of a heavy hitter peptide, stimulates growth hormone for longer periods of time, really targets fat loss. A lot of my clients love this one because if they're looking to lose weight, we'll use this as a tool, but that one becomes a lot more expensive. Sometimes it's, between $800 to sometimes $1,000
wow,
a month.
That's pricey.
It's pricey, but if you get all the other pieces in line, you might not need to use it, and you can use Sermorelin. And to, look back to what you and I were saying, because Sermorelin and growth hormone peptide can stimulate your own endogenous endogenous hormone production like testosterone and potentially other hormones, you may not need all these other additional therapies that can add up to hundreds and thousands of dollars, right? You might only need Sermorelin.
Yeah.
And you're not going to have to spend money on all the other supplements that may or not be working, or herbs or tons of other hormones, when you might just need one.
I like that. And it's upstream, as you mentioned, to all these other factors. Yeah. So I think that's really important. Yeah. And it affects multiple bodily systems. I think that's,
absolutely.
Testosterone is great for, say, muscle mass and libido and memory and all that. But if you can affect recovery, joints, collagen, hair, skin, nails, energy, everything. I mean, it seems like this is it's a casting a wider net metabolically and from an endocrine standpoint. So I really like that. I'm curious by it. I do find that my recovery as I get closer and closer to 45 is not as good as it was, say, compared to like 35. And that's why I rely upon sauna and ice bath therapy and all of that. But when I run labs in the next month, I'm going to look at my IGF binding protein and IGF-1 and all that and just see like where things are at. And
you can let me know.
Yeah, get a good idea. Last time I want to say it was like 170. I think that sounds, last time I checked. But
if you're still looking for that edge, let's say you could be content with that, and you can be content with your sleep and your health overall and your workout outcomes. But what if you're looking for that extra edge? Like maybe you want to be a little bit stronger. Maybe you want to ski better, right? Maybe you want to feel better after your workouts, like you maximize your recovery so that instead of taking a week off, after you've done a hard workout, that you shorten that recovery to 1 or 2 days, as an example. So, and I would say it's not even that you're looking for that edge, you're looking to optimize.
Sure.
So potentially you would be better if your IGF-1 was at a 200.
Yeah.
As an example.
Right. Where do you see it go? Like, so if someone is, say, like you mentioned some clients are in their 80s, with IGF-1, does it get to like 300 or is it like 250? Where do you see that?
Yeah. In a lot of patients, it'll be around 250, 270. When folks are getting to that 300 range, I'm kind of concerned.
Oh, okay.
That we're overstimulating. Plus, if other hormones start to rise, like ACTH, for example, or prolactin, are we dealing with a tumor potentially? Yeah. So it's always like a red flag once it starts going toward that 300 range.
Right. And in people who have active cancer, would there be any drawbacks to recommending this?
Yeah, let's get rid of the cancer first before putting in something that potentially can promote its growth. And this is different than saying, growth hormone does not cause cancer. Just like hormones do not cause cancer, there's usually other underlying factors that cause that. But just like with any other cancer, let's take breast cancer, right? We don't want to plump someone up with hormones when they're have an active cancer. We want to get rid of that first, and then we can absolutely safely introduce growth hormone or any other hormone into the mix.
Yeah, really good point. Thanks again for coming on the show and sharing such great wisdom. I think this is really helpful, and I will put all these articles in the show notes that we talked about today.
Amazing. Thank you so much.
My pleasure.